Hi,
How are you?
I'm fine, Gil.
Good to see you again.
Last time we did the live stream, I had this continuous echo, and I already have it back now. And
You have an
it's
echo
really
right now?
your answer, Gil.
Let's see. Figure out what's going on here.
I know you don't hear my echo, but I hear my voice 1 second after mine all the time. So
Is this any better?
let me try. Yeah, it's better.
Okay.
Yeah,
I think what's happening is I think the speakers from the computer are hitting my microphone, so I just lowered the speaker.
yeah, it's better. Thanks.
Sure.
How are you?
I'm not too bad. I'm a little sick actually. I have a cold.
Oh,
So been better, but not the end of the world.
you'll get over it. So let's take some questions. I've already gathered some from different comments on Facebook and so on. But let's start with a question. A friend of mine asked. Actually, he's on TRT since a few years, and his wife says since he's on testosterone, he started snoring at night, and she even recorded him. It's very loud,
Hmm.
and but he is not obese at all, not fat, nothing. He's not a bodybuilder with a thick neck, nothing. So, would there be any connection between snoring and testosterone, even in a not fat guy?
So people have reported both an improvement as well as an exacerbation of both snoring as well as sleep apnea. And it seems to kind of be a hit or miss depending on the individual. Some people improve, some people worsen. I personally cannot think of a particular concept or mechanism that would cause it, with the exception of um, somebody who has a broader neck or somebody who has a larger chest, potentially maybe increases in volume initially due to some weight gain from water retention, and then ultimately in the long term, possibly additional muscle training. Um, you know, People always consider training and weightlifting as something that is good, something that is healthy, and it is. But we have to understand that BMI does not discriminate between fat and muscle. Body mass index or a larger person is going to have some sort of conditions develop over time that somebody with a smaller BMI is not going to have. One of those impacts is cardiovascular health on the heart, because the heart now, as a pump, has to pump to more tissue. So even if you're muscular and you're a larger person, your heart health is going to suffer negatively for it. Secondly, is the neck circumference. In America, for example, the standards for primary care, where they say assess for sleep apnea, is a neck circumference of 16 inches. And that is not a very large neck by today's standards. A lot of men have necks over 16 inches.
Mm.
So if your neck circumference increases, whether it's from weightlift, excuse me, whether it's from weightlifting or just, being overweight, you're more susceptible to sleep apnea and or snoring. But a lot of times, snoring is not just related to obstruction in the neck or the chest. It could be a deviated septum, so it could be anecdotal. I just don't know the true answer of why it happened to this individual. But I have heard from patients both, hey, this has gotten worse as well as this has gotten better. But
Mm.
everything I just mentioned is just my own hypotheses on why this can be. I just don't see, unless someone can point me to any literature or any ideas as to why, I don't see any connection between breathing and testosterone.
Yeah, sure. Yeah. Another thing I saw on Facebook and our Facebook group, and I saw you already very shortly answered it. Can Tadalafil be used for women? And if so, what are the benefits? And is this another dose than for men?
Sure. Women have erections no different than men do. They just have slightly different anatomy. But if you look at the in the fetal state, prior to development in the womb, men and women are identical. and the female anatomy simply develops differently into a male, prior to birth. So women have erections no different than men. It's nothing more than an increase in blood flow to the region. It can heighten sensitivity, it can heighten arousal, and it works in the same fashion via the same mechanism, via the inhibition of the phosphodiesterase 5 enzyme. Dose, I would tell women, generally speaking, most women tend to be slightly smaller than men as a whole in terms of body mass. I would say start at a smaller dose. And if it works for you, great. And if it doesn't, then increase. Men like to use generally 5 milligrams a day as a base. Some men develop some side effects like pumps or cramps in the lower back, upper legs, hamstring area. Some develop some heartburn. We tell these guys usually to either try an every other day administration or cut their dose in half to 2.5 milligrams. For a woman, if she's going to go with a daily dosing protocol, I would suggest starting at about 2.5 milligrams, making sure that she is reaping any benefits, but mitigating any potential side effects from the drug. And she could titrate as needed, but I'm a big fan of starting low and slow and making sure that you don't have any detrimental effects from any drug.
Sure, thanks. Questions from the chat box. Artzilla, thank you very much for the super chat. He says, I started on TRT 3 months ago at 100 milligrams of test C split into 2 doses per week, and my total test was around 1500 nanograms per deciliter. The doc said that was too high, reduced my dosage to 80 milligrams per week, which put my test around 1250 nanograms per milliliter. What causes this hyper-responsiveness? Excuse me?
Well, after he reduced it to 80, what happened?
Then his total test was around 1250. And then he asks, what causes this hyper-responsiveness to testosterone?
It's not hyper-responsive. He failed to provide the most essential key number that I look for when treating men on testosterone, and that is sex hormone binding globulin. Because the higher your sex hormone binding globulin level is, the higher your total testosterone will be. This is a buffer, sort of like it's a binding protein essentially in the blood produced in the liver. And the more of it that you have, and it does increase with age and certain lifestyles, the more of it you have, the less of your testosterone is available to be utilized as free T. And therefore, you're kind of banking it. So every single time he's injecting his testosterone, he is saving more of it as a total. So that I've seen total Ts that are significantly high. This is not a hyper response. This is all of your T going into the bank and none of it being utilized and metabolized and excreted, essentially. So high SHBG guys have high totals and low free. Low SHBG guys have low totals and high free. So I can promise you that if this man tested his SHBG, it would be above 50, 60, 70, and so forth. In my opinion, probably north of 80 or 90 based on the numbers he's providing.
But if he feels good, he doesn't have to do anything about it, probably.
There's no harm to having your total T up there. Without SHB, excuse me, without SHBG, his provider cannot responsibly manage his protocol. You simply, if you don't understand the mechanism of SHBG and what effects it has on this hormone, then you should not be treating a man for T, and you should not be chasing a total number. Total T is irrelevant. It's like looking at someone's savings account, but not looking at their checking account. You have the access to the money, but they don't have the money available to them. They can't use it. They're still going to feel, you can have 10 million in your savings, but if you have no money in your checking, no debit card, no checks, and no ability to transfer that money, you can still feel like you're poor, aka be symptomatic. So
David Kammitzer says, Gil, I saw your post about finishing up teaching the other docs. What's next for you, my friends?
Nothing changes. I'm just taking one thing off my plate. I am doing a lot on a daily basis. We all have 24 hours in a day. I just choose to spend all of mine doing things that I'm passionate about. I got to a point where after several years of doing this every other week, I feel that I have done what I wanted to do for the colleagues of mine in the industry that needed it. They've had an opportunity now for 2 years to book this, and most of them have been booked 6 to 12 months out. And I just value my free time to not lock myself in for 3 days every other week to my office. So nothing changes. Everything else that I continue to do is moving forward. I just am not going to be teaching anymore.
Yeah, sure. Hi, David, who's watching from Belgium. David also asks, David Kamitzer, what's next for you, my friend? Yeah, that was it. Justin, what are your thoughts on taking selenium with TRT and helping regulate estrogen?
So selenium and iodine specifically, when paired together, are good support for your thyroid. Um, Regulating estrogen is not something that we ever even consider discussing because it is a self-regulated intracrine hormone in men. It is a metabolite. It is not something that needs to be even checked. You really can't check it if you understand the mechanism of how it is produced and where it is produced. You really can't test it in a man properly, nor do you need to. So selenium, no harm, good for the thyroid, has nothing to do with estrogen, and please don't bother even worrying about estrogen.
Mm-hmm. Thank you, Farmer Rick, for the super chat. And yeah, there he asks, Gil, best protocol to lower my E2, but what is the reason you want to lower your E2, right? He says loss of libido and sensitivity once I passed about 45. Estrogen, probably.
What guys often think is high estrogen symptoms, which, by the way, does not exist. There's no such thing as high estrogen in a man. It doesn't exist because estrogen is produced from testosterone. So if you have high estrogen, you have optimal testosterone, and they counterbalance. So there's no such thing as too much estrogen in a man if you're not injecting exogenous estrogen. What guys often confuse as high estrogen symptoms are actually high free testosterone symptoms. So again, check your SHBG and then calculate your free T based on that. And you may need an adjustment to that. You may have to fix your metabolic issues that are possibly causing your SHBG to be low. And therefore, in the interim, you may need to adjust your dosing down and or increase your frequency to inhibit the crushing effect of androgens on lowering SHBG further.
Yeah, Farmer Rick, he gives us these numbers of total T 1200 and free T 263.
263, he's referring to picograms per milliliter.
Probably.
So there will be 26 nanograms.
Yeah.
But what was his total?
1200.
1200. So he's right around the 2.5% mark. So that's about right. So then his SHBG is going to be right around 30 or 35. So everyone is different. If you feel, I mean, that is generally what most people find symptom resolution. It may be too much for him. Maybe too much for him. Or it could be other issues. Got to check your prolactin. Prolactin is a big sexual function inhibitor when that elevates. So if your prolactin is high, that's going to diminish your sexual function. So guys need to just stop blaming estrogen for everything that goes bad in the world. It's never estrogen. It really isn't. The only thing I've seen estrogen be responsible for is when it's too low after inhibition. When guys come off of an anastrozole, or when guys are on an anastrozole, that's when I see estrogen problems, when it's too low. But there's no such thing as too much estrogen in a man. It just doesn't exist. You produce it intracellularly, and then the rest is excreted. 85% of your estrogen is excreted in urine anyway. And again, it's self-regulated. So.
Someone sent me a very general question for you, Gil. What misconceptions about hormone optimization do you encounter most often, and how do you address them?
I think the biggest misconception that we all get is that testosterone is going to cause strokes and heart attacks and cancer. Those are probably the top three that I hear from people coming in, whether it be from the general media, the public, or from other physicians that are refusing treatment, and then these guys are coming in seeking treatment. My first answer to anyone that says testosterone is going to cause a heart attack, a stroke, cancer, etc., is I say whoever made that claim needs to prove their claim. You're going to make a claim, the burden of proof is on you. I don't need to prove that it doesn't. You need to prove that it does, right? Because you're the one that's claiming that a new event is going to occur if you use this input. And they can't. They cannot prove it. All I ever get is, well, my doctor's been doing this for 30 years. That's great. So he's been wrong for 30 years. That tells me nothing. A lot of people have been doing a lot of things for a very long time. It doesn't mean that they are correct. Heck, I've been wrong on a lot of things in life. The minute I am proven wrong, I change my tune, I apologize, I learn, and I develop a new path. That is what makes human beings so spectacular, is we can adapt, we can accept, and we can learn the right thing. Sticking to erroneous information for your ego is not going to help your ego in the long run, and it's certainly not going to help your patients. So rather than just opening up a debate and trying to stand my ground and prove them wrong, I just ask them to prove it, and they never can. They never can. And if anybody wants to have any ammunition in their back pocket regarding cardiovascular health and testosterone, in June of 2023, the largest study ever conducted with human beings and testosterone, specifically for cardiovascular health, was conducted and published. And it is called the Traverse trial. You can look it up. And it is fairly lengthy and it is fairly conclusive. And it clearly shows that men with low testosterone levels are at a far greater risk for all arteriosclerotic cardiovascular disease than men with optimal levels. And that is some of the most extensive and latest research that we have available. So anyone harping studies from the 70s, 80s, 90s that is purely correlative and inconclusive should refer to the newer and more conclusive studies and stop, beating the desk on nonsense. But that is probably the biggest misconception.
Thanks. Our friend Ardilla, who talked about his so-called hyper-responsiveness, he says his SHBG was 81 nanomoles per liter.
What did I say? I said I guarantee you it's probably around 80 or maybe 90. That is why he thinks he's hyper-responding. He's not. You're banking all your testosterone. Every time you're taking an injection, your total goes up. Very little of it is free. About 1 to 1.5% of your total is actually free with that SHBG level. So you're really not using a whole lot, but all of it's going in the bank. So the number keeps going up on the total, but your free is still suboptimal. So by reducing your dose, you're only becoming more symptomatic. You need to fix the underlying cause. Here's the good news. The longer you stay on testosterone when done correctly, and I hope he's doing at least 2 injections a week, SHBG will naturally start to come down. High SHBG in and of itself, and that's not, that is on the higher side. That is not abnormally high. It doesn't alarm me for any sort of liver disease or anything like that. But the SHBG where he's at has actually been associated with longevity. And I would imagine that he may be in Europe because a lot of Europeans follow a more Mediterranean diet that is lower in carbohydrates, and that usually drives SHBG a little bit higher, whereas Americans, on the flip side, tend to have really low SHBG because we lead the world in metabolic syndrome, specifically diabetes and insulin resistance. And insulin is the largest antagonist of SHBG. So anyone that has hyperinsulin in their blood chronically is going to have a very low SHBG level, therefore a high percentage of free testosterone, a lower total, and they're going to constantly keep raising their dose because they think their total is the essential number. Meanwhile, that crushes SHBG even further, and then they become highly symptomatic for sexual dysfunctions. So a lot of the metabolic patients that we get here in America that are transfers from other clinics that are on 200 milligrams a week or whatnot, their SHBGs are single digits, and they don't understand why they felt great the first couple of months, and now for the past year or two, they've just been in the toilet with their life. And it's an uphill battle to try to explain this. This is one of the things I've taught to providers for the last couple of years, in my office when they come in, but some of them even struggle with the concept. So explaining this to a non-medical person gets a little challenging. So, I try to put the videos up there. I tell people, look, if you're a curious type and you really want to learn and you understand anatomy, pay attention. If not, just trust us. Go by how you feel. They noticed that within a couple months of coming into our office or transferring over, they feel significantly better. There's a reason for that. It's not by accident. It's by design.
Do you think free testosterone levels of 20 nanograms per deciliter in a trough, so 12 hours after applying the cream, is still optimal?
If you feel well, sure. I mean, I tell guys, most men that I've seen will find symptom resolution when they're free testosterone. And I hate absolute numbers, but if I have to put numbers on to encompass 85% of the population that I have experienced, I would say 20 to 30 is where most guys tend to find symptom resolution. Some outliers do need a little bit more. Some guys feel great, a little bit below. I've seen guys with a, 16, 17. They say, I feel good. We leave them alone. We don't touch them. But 20, yeah, I mean, that's a great start. If you feel good, leave it alone. I mean, more isn't always better. I've seen guys, say, well, I'm at the bottom end of that range. Maybe I should shoot for 25. And now they start having issues. But again, the more you utilize with androgens, the more you crush SHBG. So it really depends not just on your free T, it depends on where your SHBG is, and it depends on how you feel, and it depends on where your hematology panel is, because we don't want to push you into areas that are going to start creating potential problems with other providers and, causing alarms and all these other things. So it's really a balance of everything. So I would say if you feel good, enjoy, and if you don't, then get a further assessment.
Mm-hmm. Do you have any recommendations for a woman 47 years old that had estrogen-positive breast cancer, currently having mood, inflammation, and low-level psychological issues?
Yeah, so my question for this woman, and I no longer treat women, but I do want to answer her question. I have two questions for her. Number one, is she pre, post, or perimenopause? And then number two is, she says she's being treated for breast cancer. I'd like to know what kind of medication is she taking? Is she taking an anastrozole and or tamoxifen? And what other medications? And once I have that, I can tell her what scientifically is going to probably help her. With that said, I'm not going to give her medical advice because she's being treated by an oncologist, and that's the person that's responsible for her care. So I would never override that over the internet, but I can give her my feedback, my opinion, but those are two questions I need. Where are you at with regards to menstrual cycle? Are you still cycling regularly? Are you kind of in between perimenopausal state, or are you postmenopause? And then secondly, which medication are they using to treat your cancer? And is it in remission, or is it still actively being targeted?
Mm-hmm. Okay, leave those questions in the chat box. Again, coming back to our friend Artzilla with the high SHBG, he says, I am Canadian, I do eat low carb, and I am sub 10% body fat. Plus, I work out intensely 6 days a week.
Yeah, that is why. So cardiovascular activity increases SHBG. Low carb diets or the absence of insulin increases SHBG. Aging increases SHBG. He's got all of the things that increase SHBG. As I said before, SHBG is associated with longevity, and low SHBG is associated with all-cause mortality. So it's not a bad thing. It just means that he needs a higher total number in order to have sufficient free testosterone to resolve his symptoms. And unfortunately, he's dealing with a provider who is alarmed when they see that 1,500 total, not understanding the binding mechanism of this protein that is taking his free testosterone ratio down to about 1% of his total. All right. When your SHBG is in an optimal range, then your free T is about 2.5%. You just are using less of it, so you're banking more of it, causing an artificially inflated total T level. Just means you need a little bit more, and that's okay. At least for me, that's okay. Obviously, for his provider, it's a reason for alarm. So dropping him to 80 milligrams a week, it's certainly not going to help him feel any better. But try. And I sympathize with Canadians because it seems like a nightmare up there to try to get proper care. Nobody in Canada seems to be doing this right, and they're all posting in the group regularly, and they're calling my office, hey, can you treat? And I say, no, we're licensed in all 50 states, but we can only treat in the United States. And they say, I'm struggling to find someone competent up in Canada. I don't want to make this a political conversation, but if they made Canada the 51st state, at least you TRT guys will be able to call me and we'll be able to get you going. You'll have options. I mean, me and there's a lot of other great people in this country that do this correctly. So you guys will have wide, broad access to therapy if that happens. But for the time being, you just got to do the best you can, and maybe try to explain it. Show him my SHBG video, and I mean, if he's not an ego guy and he's open to understanding this better, then he'll understand the concept.
Yeah. Go to the YouTube channel's homepage, type in SHBG, and you'll find several videos that Gil did about it. High SHBG protocol, it's called probably. So we have more info on the 47-year-old woman with breast cancer, Gil. Pre-menopause, used to take tamoxifen, but not in the last 6 years. Currently in remission with no medications. She had a double mastectomy 7 years ago.
Okay. So I'm sure that her docs are telling her, estrogen is going to cause problems. If she's still premenopause, I would say get a full hormone panel done. Check your testosterone, your estrogen, your progesterone, and also your thyroid. Because based on the moods and depressive feelings she's reporting, don't discount the thyroid. Check that as well, especially in aging women. She may just do fine with a low dose testosterone at this point. If her estradiol and progesterone are okay, she may do fine with a low dose testosterone. She may need a little progesterone, micronized progesterone before bed. Make sure you're using bioidentical hormones for women. Do not use progestins. Do not use Premarin, which is a conjugated equine estrogen, which is what the Women's Health Initiative back in 2001 published, that this increases the rate of breast cancer. This was not a bioidentical estradiol. It was not 17-beta estradiol that is produced in humans. You may not even need estradiol at this point in your life. If you're still cycling regularly and it's not deficient, I would let that one be. But you could do a very small dose of testosterone, maybe improve some of your symptoms. Look into possibly a little progesterone before bedtime to calm you down and reduce anxiety and help improve sleep. Quality sleep will do wonders for your mood overall throughout the day. And like I said, look into your thyroid as well at this point in the game. And then continue to monitor and find a women's health provider that is proficient, so that as you start, because you are of age, and in the next couple of years, you're going to go through peri and then eventually, menopause, and you're going to need to replace all 3 hormones. I would not necessarily shy away from properly administered estradiol for a woman post-mastectomy. I mean, we've treated women with the BRCA gene, high cancer risk women. This is a natural hormone that your body makes. I had a conversation just the other day with a woman about this, and I said, I have a question for you because I'd like a woman's perspective. You've been on HRT now for a couple of years. You're feeling great. Everything is good. You happen to be what they call genetically a high-risk breast cancer candidate. If I told you that you are increasing your risk, and this is not what we're saying at all, but hypothetically, if I said you are increasing your risk for breast cancer by staying on this therapy, or you can stop this therapy now, what would you choose to do? She said, instantly, I would stay on this therapy. She said, the quality of my life and the way that I feel now is worth every ounce of potential risk compared to going to a postmenopausal state that I was in previously and feeling like absolute crap. She said, if you told me I was cutting a decade off the back end of my life, I would still stay on the therapy. So that's just, subjective feedback from someone who's been on. This is an individual decision. I personally do not believe that taking a bioidentical hormone that your body produced your entire life and now is no longer producing, becoming, osteoporotic, becoming depressed, gaining weight, losing, your bodily functions and your strength and your muscle. I don't believe that that is graceful aging. I don't believe that the potential risk of maybe developing cancer. If we live long enough, we're all going to have cancer. I mean, you're a dermatologist. If I make it to 100, will I have skin cancer? Probably 3 or 4 times along the way, right?
Yeah,
so
sure.
if we live long enough, every man's going to have prostate cancer and skin cancer. Lung cancer is a big one that, we'll all die of respiratory failure eventually if we don't get killed before that. So we can't just keep worrying about the what ifs. We have to improve our quality of life. And there's really no evidence to suggest that you are at imminent and an increased risk by doing something that your body requires and something that your body had and something that it craves, as long as it's done correctly. So it's a personal decision, but it's one that women should consider themselves. It's not for the provider to make. Well, our job is to educate you, present you with the literature, present you with the anecdotal experience we have, and then ultimately you come to a decision of what's good for you. People go out and drink alcohol. They know it's bad for them. That's not a hypothetical. That is a guaranteed harm to your body, and we choose to do it for instant gratification. For the hour or two that we're out socially and we feel better with that drink in our hand, we are shortening our life. We are impacting every body function and every body system in a negative way. We still choose to do it. People do it every morning when they're at the Starbucks or Dunkin' Donuts drive-thru or McDonald's. They do it every day for instant gratification. So now we're vilifying a natural hormone that our body needs by saying maybe potentially someone said that your risk may be increased. Okay, we do so many things that are guaranteed to harm us every day for the sake of pleasure, and yet we vilify something like this. To me, it just doesn't add up. We gotta like really take a step back and look at the forest and stop being so fixated on the nonsense.
Yeah. A question for Gil. Have you ever used HCG in addition to the TRT? And if so, what is your experience with it?
Oh, absolutely. We do this as an adjunct all the time with guys, but again, not with everyone. Not everyone needs it. Not everyone will benefit from it. So first we have to understand what HCG is. Excuse me. I believe the person asking the question probably understands it to a degree, but for those who don't, I just want to give like a very brief explanation. So HCG stands for human chorionic gonadotropin, fancy word for the pregnancy hormone that is released in a woman's urine or detected in a woman's urine when she is pregnant. What HCG does when it is injected by a man is it mimics, doesn't increase, but mimics a hormone called LH or luteinizing hormone. And that is a hormone that is generally in a healthy male secreted by the pituitary gland, the anterior pituitary in the front. It is secreted into the bloodstream. It goes down to the testicles and it works on the interstitial Leydig cells to stimulate production of testosterone. In the process, it also helps to maintain testicular function, and that testosterone production and intracellular aromatization or conversion into estradiol helps the Sertoli cells in the testes produce sperm. That's a process called spermatogenesis. For all of this to occur, we have to have two things present. We have to have good functional Leydig cells and good functional Sertoli cells. Here's the problem. When we make a diagnosis, and we always diagnose our patients prior to prescribing testosterone, most people do not, and that's a problem because low testosterone is not a diagnosis. Low testosterone is a sign. It is something you can see on a piece of paper on a lab report. Low testosterone is associated with symptoms. So you have the sign and then you have the associated symptoms. Neither is a diagnosis. A medical diagnosis is something that could be pinpointed as to why it occurred. What is the etiology or the cause behind it? So when we diagnose a man who suffers from low testosterone-like symptoms, we look at the chain of command of the luteinizing hormone from the pituitary and the signaling agent that goes to the testes, and we try to figure out where this chain broke or where it failed. In a male who is diagnosed with what we call testicular hypofunction / primary hypogonadism, his testes or his Leydig cells have failed. They're essentially either dying or they are dead already. In someone with secondary hypogonadism, the pituitary is failing to send a signal down to the testes. So if you are secondary and that pituitary signal is deficient, giving you a mimetic like HCG, which mimics luteinizing hormone, while it is suppressive to the pituitary, will in fact stimulate the Leydig cells to continue working. This does a number of things that are wonderful for some guys. It may help to preserve testicular function and prevent mild testicular atrophy, which is a fancy word for shrinkage of the testicles. It is purely cosmetic. There's no risk factors associated, but some guys don't like the cosmetic effects, so they complain of it. And I will state that probably maybe 20 or 25% of all patients on testosterone ever report experiencing this, so it is not as common as you think. And the second thing is because we're stimulating very slight endogenous testosterone production from the latex cells, the Sertoli cells benefit by maintaining some level of spermatogenesis. So this is very nice for guys who are, one, diagnosed with secondary hypogonadism, and two, still want to maintain some level of fertility in the future, coupled with prevention of testicular atrophy.
Mhm.
Where does this not apply is for guys who are a definitively strong primary hypogonadal candidate, where their testicular function is completely diminished. Mimicking luteinizing hormone in otherwise non-functional testes is completely moot. It is a waste of money, and you're just buying expensive water at that point. So
Mhm.
I apologize for the mildly complex explanation, but HCG is not a one-size-fits-all. It has to first be looked at from a diagnostic standpoint and does it fit into the equation or not. And this requires someone who understands the mechanism of the HPTA and why someone's production actually failed.
Yeah, very clear. Thanks. Bit of a special question. What ethical considerations should be taken into account when prescribing hormone therapy, particularly regarding long-term effects and dependency?
Well, okay, so anytime you do anything for another human being, ethics come into play, and you should always practice ethically. You should always have the patient's best interest at heart. There should be no outside factors that drive your decision-making process. When I say decision-making process, it is the decision to either prescribe or not prescribe. The decision to actually move forward with a treatment or not always lies with the patient themselves. Patients have the right to deny any treatment, and you do not decide if someone will do something or not. You decide if you're willing to help them in the process. Your decision should always be driven by ethics, and those ethics should be based with an end goal of doing the right thing for the patient to improve their quality of life and improve their health. Sometimes it's contradictory. Palliative care is a common example where you may improve quality of life, but you're going to harm their health. But this is an end of life type of a treatment. What we're doing here is kind of like it's not palliative care, and it's not exactly, look, you're sick and I'm just going to treat you for better health. Because if you look at some treatments like cancer, you're being treated with chemotherapy, they are worsening your quality of life transiently, but they're improving your health long term. We're right in the middle. We're kind of saying, look, we believe that we're improving your quality of life, but at the same time, we're also lengthening your life. That's what we truly believe, and we do have literature to support it. As with anything in medicine, when you have literature supporting one side, you're going to have another one, against. So it's really hard to look at evidence-based medicine the way they want us to look at it and say, what does the evidence show? Well, the evidence is always usually going to show both. It kind of depends on how you interpret it. So, we hate to debate the philosophy of it. We just look at, honestly, after thousands of case studies, we looked at the anecdotal evidence. How do people feel? What is their time span? What is their longevity? What are other health markers doing? So we noticed that when we induce properly administered, key term I cannot emphasize enough, properly administered testosterone therapy, properly administered, properly management with good oversight. Because the term TRT gets tossed around, it means nothing unless we know the specifics. So properly administered, properly managed, properly supervised TRT, we've noticed a handful of things. Number one, symptom resolution is generally achieved in a relatively short period of time. Number two, we notice that a lot of markers in other arenas improve. Anemias are reversed, sexual dysfunctions are reversed, quality of life is enhanced, mood and cognition are enhanced. People are starting to now throw away prescription medications. Hypertension is improved, and people are starting to now come off some of their antihypertensives. People have come off of statins. People have come off antipsychotics, SSRIs, SNRIs, benzos. They've tossed these drugs, which generally just masked an underlying problem once their hormonal balance has been restored. So, so ethically, I am completely confident in our decision to help somebody with treatment if they are, one, symptomatic, and two, especially if they show clear signs of suboptimal levels. You don't always have to have a clinical deficiency to be treated. Suboptimal is very subjective. And if you are symptomatic And I see no harm in treating you because he used the word dependence. Nobody is dependent on anything when it comes to this. You're not a type 1 diabetic who will die without insulin. You're using testosterone. If you stop taking testosterone, you're not going to die. So you're not dependent. The quality of your life may feel like it's dependent, but you're not dependent. You are dependent on food, water, air, shelter. You will die without those things. You're certainly not dependent on your testosterone. You can come off, and you can probably even start producing your own levels. Again, the problem is if you were suboptimal to start, you're going to be suboptimal if you stop. So you're certainly not dependent. I know that scares a lot of guys, but if you got on for the right reasons, really you shouldn't be stopping anyway. Just again, make sure that it is being treated by someone who understands how to treat, manage, and supervise your treatment on an ongoing basis. Your body is always evolving. Your metrics are always changing. The variables are changing. Metabolism changes. SHBG changes. Your needs and your lifestyle changes. And understanding how to change things on the fly to adapt to your needs prevents bad side effects from happening in the future and then spending months trying to undo them with someone else.
Getting back to HCG a bit, what are your thoughts of kisspeptin versus HCG to keep natural systems running while on TRT?
I'm a big fan of HCG. There's no reason not to use it. It's a direct analog for LH or mimicker. Kisspeptin would be like the next best choice. I do not like gonadorelin. Gonadorelin is a GnRH mimicker. It's upstream. It kind of like bypasses the hypothalamus, but still requires proper pituitary function in order to operate well. So HCG is my number one favorite still.
Can high doses of TRT cause myocarditis?
High doses is not something, well, the word high is subjective. It's not a definitive word. I don't know what he means by high, but I mean, we prescribe medical doses that bring people to symptom resolution without causing issues. Sure, can you get inflammation of the heart space? Yeah, I mean, potentially. I mean, you can get fluid retention. People can develop edema, possibly CHF, possibly pneumonia. I mean, if they have too much fluid retention. But again, it's not really something that I ever see with testosterone. It's guys that abuse steroids that usually run into problems. It's not anything I've ever seen in the thousands and thousands and countless. I don't know if I had to look back at our charts. I think I've treated over 10,000 men at this point, and it's not something I've ever seen directly linked whatsoever. So I don't really concern myself with what they consider to be high doses because that's not medicine.
An associated question. When is too high testosterone levels dangerous? I'm at 1600, but I feel great. It's just a number. I'm 37.
I don't know what his SHBG is. I don't know what his free T is. I don't know what his hematologic panel looks like. His CBC, his CMP. I don't know anything about the guy. In and of itself is, am I alarmed when I see a total T of 1600? In and of itself, no. That doesn't alarm me. I need a lot more information.
Would there be any number in 3T that is alarming associated with that?
Again, you have to see the full picture. I mean, if his total is 1600 and his SHBG is low, then he's taking too much testosterone. If your SHBG is low, you'll never be able to achieve a level that high in your total because you're getting so much free and a lot of it is being metabolized. You'll never bank enough to get to 16 unless you're taking 500 to a gram a week. I've never seen a man with an SHBG under 20 with levels 1600 under medical care. Not when it's done correctly. So I would be alarmed if his total is 1600 and his free T ratio is over 3%, then I would say you're doing something wrong here.
Yeah. What should I expect during the initial phase of TRT? What changes might I notice in the first few months?
I'm going to go on the assumption that it's being done perfectly correct because I don't know what they're doing and what they're not doing. So I can't answer to your specific situation, but I know for our patients, usually by week 3 or 4, most report an improved sense of well-being, an improved outlook on life and future, and libido and mood and desire to be productive and get out of bed and conquer their day. So it's more of a mindset cognition type of an improvement is the first thing we've noticed. Usually by 3 to 6 month period, we'll notice some body composition changes, increases in strength, lean body mass, some fat loss. And then usually you'll notice some cardiovascular improvements that are measurable, whether it be cholesterol, blood pressure, arterial function, etc., within the first year. And some studies that I've read have said that even up until the 36-month mark, there's still improvements to bone mineral density.
Mm-hmm.
So it's still an upward linear curve when it comes to making your body stronger and improving your bones for 3 years after initiating treatment, which is beautiful because it just means that, you're not done seeing all the results. Now, bone mineral density is not immediately tangible. We can't close my eyes and say, well, I'm just imagining my bones are stronger. But hey, when you take a spill, I mean, I've taken some hits accidentally. I've fallen on my hip. I kind of twisted my leg once by accident. Things that normally I should have said, damn, I think that would have broke had I not been on testosterone for a decade. At my age, I think I would have broke that leg. I've dropped things on my foot. You got a lot of small bones in that foot. I've dropped things on my foot that are heavy, and I said, "Oh, I think I just broke my foot." And it's bruised for a day, and I'm fine, and I'm walking on it, and nothing broke. It's bones are strong. Bones are strong. Vitamin D, calcium, good protein, good sleep, good recovery, and some testosterone, and your bones are baseball bats, man. So yeah, just the longer you stay on, I mean, you should be on for life, but know that for the first 3 years, you're still making improvements.
Mm-hmm. Hi, Roy Martin. And there was another question. What's the minimum dose for building muscle, as I don't seem very anabolic at 100 milligrams?
Building muscle has nothing to do with a dose. Building muscle has to do with proper training, proper nutrition, and proper sleep. I don't see it behind them now. I think that's a different book, perhaps, that blue one. But Steve wrote a book on diet and training. I don't know if you have it translated into English.
No, I have not, but
Okay. All right,
yeah.
there you go. So I would imagine he knows a thing or two about lifting and eating because he's just a physical specimen over there. So yeah, I mean, get if if you speak Dutch, then get Steve's book, and if you don't, maybe ask him for a referral to an English version. But learn how to really train correctly for your intended goal. Learn how to really eat correctly for your intended goal, and make sure you get plenty of sleep because nothing happens without good sleep. I promise you, it's not your testosterone.
Mm-hmm.
It's really not. It's like going on a journey in your car and then saying, what music should I play to get there faster? It's just like, that's just something in the journey. It really is like the last bit of anything that has to do with how quickly and how effectively you're going to get to your muscle goals. I've seen guys with low T build physiques, and I've seen guys with really good T levels that lay on the couch and do nothing actually look like slobs. So I know you're probably training, you think you're doing things right. I'm not trying to be antagonistic here, but here's the deal. If you're not happy with your results, then your body says otherwise. It's not about my opinion, your opinion. The bottom line is if your results are not happening, then your input doesn't justify the output. Change the input. Change it. All right? Put the ego aside, ask for help, research, do your homework. You got to lift with intent. Watch CM Sulek. Watch how that guy trains. The guy trains to failure on every damn set. Every set, he'll go to full failure. And that's what's required to really cause muscle adaptation. Your body's very content where it is. That's why it's how it is. Whatever body you have right now is conducive to your daily activities. Your body adapted to your lifestyle. And if your body is going to change, your lifestyle has to change. Your training has to change. Your nutrition has to change. Your sleep has to change. If you're doing everything the same for last year and you got no results, change it. It's not your 100 milligrams. I promise you. It's not. I wish it was that easy. It's not.
Associated, there was one last general question I gathered. Can you explain how lifestyle factors like diet, exercise, and sleep influence hormone levels? What changes would you recommend for optimal hormonal health?
When a man is slightly older and he's suboptimal and symptomatic, I do recommend the lifestyle changes, and I will go over some of them, and I do recommend them for every living person regardless, because it's just good to do good things for your body. But to think that that's going to optimize your hormones is probably a long shot. I would say properly administered hormone replacement is the answer. Now, if you're young and you are suffering from suboptimal hormones, more often than not, it is self-induced based on lifestyle choices. And those people will see marginally better results when they change their lifestyle. Guys my age, your age, I think we're the same age actually. Um, at this point in our life, we need to be on replacement therapy. It's not, eating better and sleeping more is not going to optimize us. If we get a 10 or 20% bump in our natural production, it's still deficient for where we want to feel. But if you're 22 years old and you're not happy with your hormone profile, reassess what you're doing. I'm going to give you the scientific answers. And if you think that they're unattainable, then do the best you can. I know people are going to say, well, that's not realistic. I get it. I'm going to tell you what science wants your body to do, and then you meet it halfway or three quarters or wherever you want. Zero alcohol. Absolutely zero. Never, ever, ever, ever have an alcoholic beverage for the rest of your life. That is the scientific answer, first and foremost, because it's one of the most toxic things on the planet. And I know a lot of people are going to be like, well, no, I can't do that. Okay, fine. I gave you the answer. You don't have to listen. So just have less drinks, or just don't drink as often. But zero alcohol is going to be your best friend. Sleep. Get 8 or 9 hours of sleep every single night uninterrupted. Again, people are going to say, I can't. I got to be up for work. I get it. I'm telling you what the answer is. Do the best you can. If you're sleeping 4 hours, try for 6. Go to bed an hour earlier. You know what I mean? Don't play with your phone. Don't watch TV before bed so you get deeper REM sleep. Maybe read a book and put on some low light so that you're not interrupting your sleep pattern. Caffeine. I know everyone's going to say, oh, it's an antioxidant. Caffeine's a good stimulant. It enhances brain activity. Yes, but caffeine also greatly disrupts sleep. The half-life is longer than you realize. If you have a cup of coffee midday, it's going to interrupt your sleep at night. So cutting out caffeine altogether, and again, I understand it's not realistic. Hey, I'm drinking a protein coffee with caffeine right now. I usually have coffee in the morning. I'm not perfect, but I am telling you what scientifically your body requires to be optimal. Okay? So optimization comes from doing things correctly. Avoid alcohol, sleep better, avoid caffeine, avoid stimulants, avoid sugar. Sugar is terrible for everything. Now, notice I didn't say avoid carbohydrates. I said avoid sugar. Okay? You can eat vegetables. They contain carbohydrates. You can eat starches like potatoes. They contain carbohydrates. But ensure that you eat your carbs with proteins and fiber to lower the glycemic index and the insulin spikes so you have a more level blood sugar level. Getting your blood sugar to 180 or 200 is going to cause problems in your body. It's going to lead to insulin resistance over time. It's going to lead to cancer over time. Lower your blood sugar. Have it more stable. Get your A1C down to 5 or 4.9 or 4.8, ideally. I know it's difficult. It's difficult in America where we have shit for food. But again, I'm giving you the best case scenario. And if you meet me 70% of the way, you're still making improvements. So to recap, if you are 35, 40, 45 or older, consider being monitored, tested, evaluated, and treated potentially by a competent provider for hormone therapy replacement. And if you're a young guy and you're suboptimal, then those changes are really all you should be focused on at the time. If you're older and you are on hormones, you should still focus on the changes I just mentioned. And those are just basics. Those are just basics that we're all guilty of. Alcohol, poor sleep, sugar, and caffeine. Those 4 things will be life-changing for the quality of your life. Pick and choose your battles, but in a perfect world, those are the 4 that I would go with when it comes to the top worst habits that people have that they really don't see as bad habits.
Yeah, agree. Um, Thank you for the super chat. Is there anything like an insulin pen for TRT on the market? When not, why? I could be very convenient for microdosing.
Yes, there is a product called Zyosted. It is 75 milligrams per ml. It is testosterone enanthate. It's absolutely terrible. I hate it. You don't need to quote unquote microdose. I don't know where this nonsense originated. You need your SHBG monitored and you need to be frequented accordingly. Very, very, very few people need to inject more than 3 times a week. And even the few that I do that with, like daily injections, it's only temporarily until they fix their SHBG problem, and then we go back to 3 times a week or twice a week. So you don't need daily injections. You simply don't. People think it mimics like a circadian rhythm. It doesn't. It doesn't, because you're using a half-life of 7 days approximately on this medication. Once you hit a steady state on a drug, which is 5 half-lives, in the case of testosterone cypionate, it's 35 days of no changes to frequency or dose. You're in a steady state. There's no more changes. There's no more peaks or valleys. So it's just not necessary. It really is not necessary. We do it for a short period of time because androgens lower SHBG and it's dose dependent. So by minimizing the dose while maintaining total weekly milligrams, we're able to stop the crushing effect on SHBG while we're making lifestyle changes to mitigate what crushed it in the first place, usually related to insulin and metabolic factors. So once SHBG normalizes and stabilizes into an optimal level, we go back to the frequency that is far more convenient. So you simply do not need the EpiPen nonsense.
Okay. Before we close off, Gil, not there are always some new viewers on the channel. If they don't know you yet, how can they reach you? Do they have to come to the clinic? What states do you treat?
We now are in 50 states within the United States, all 50 states. And we have patients all over the country via telemedicine. Our telemedicine platform has now outgrown our local patient base. It's probably about 60-40 now. About 60% of my patients do not live in a state where I have an office. And they can go to elevatewellnessgroup.com, which is my clinic website, elevatewellnessgroup.com. They can put in their name, phone number, and email address and just select telemed from the drop-down menu. Someone from my office will reach out to them within 1 to 2 business days of that coming in and go over our entire program with them. At that point, if they like what they hear, they can move forward and get started. If they don't, no harm, no foul. At least they have some understanding of how the process works.
They don't have to come and see one of your staff members in the clinic at least once, no?
No, at the moment, the current prescribing guidelines for controlled substances do not require an in-person visit. So
And
it's
how
been that
do
way for a couple of years.
the blood tests work then? They have to go to a local clinic to have their blood drawn?
No clinic. So we use we use national labs like LabCorp, which are available all over the United States. We have the patient go to their website, put in their zip code, and they find the local blood center near them, which is usually within a couple of minutes from their home in most cities in the country. We send a requisition directly to the lab, which is billed to our account with all the panels that we need. Once they go in and get their blood done, it comes back to us. It's uploaded into their chart. My office calls, schedules them for an appointment with one of my providers to go over their labs, to do a full review, to listen to their symptoms. It's usually a 30 or 40-minute conversation initially. And at that point, they will make a recommendation and prescribe them a therapy. If they choose to move forward with that therapy, it's handled on that very day, and everything from a pharmacy is shipped directly to their home. If they choose not to move forward with that therapy, everything is documented. They have some information. They have a diagnosis as to what's wrong with them. They have some advice as to what to fix in their life. And they can choose to, recheck it again in the future if they'd like.
Mm-hmm. Yeah, sounds very easy.
Extremely easy.
Nothing we have here in Europe.
We're taking in, probably 300 or 400 names like this per week, and we're probably onboarding 40 or 50 people every week of therapy. So we got to a point where we were so busy we kind of shut down taking new patients for a while. I recently hired and trained some more staff, so we're in a position now where we're kind of caught up, and shouldn't be more than 1-2 weeks out now to actually get people going for consultations. So for now, we're seeing new patients again.
How many staff members do you have to cover all that?
Oh, so I think I have 11. I have 11 people working full time to make sure all the patients are seen, not including myself. I don't really see patients anymore unless we are so slammed where somebody's just going to fall off the schedule, and I'll once in a while I'll make the call, or if we have them in house, I'll go in the room and do their consult, because sometimes my staff is just they're tied up, and some guys need a little more attention, and they may have a schedule, but then the consult runs a little over. They don't want to cut them short, so they'll call me and say, hey, the guy in room 2, or this guy, my 4 o'clock, I can't, I'm still on the line, can you take him for me? So then I'll get on and I'll do the consultation for him. I try not to do that on a daily basis, but lately we've been busy enough. I've been kind of forced to get my feet wet again.
Awesome, Gil. Thanks for explaining, and thank you for doing this live Q&A, because you're sick and it's really appreciated, man.
We make commitments, and unless I'm on my deathbed, I'm going to show up. That's one trait about me, and one thing I recommend to every man, woman, and child: own your commitments. Make no excuses for anything. Own your commitments. Own your mistakes. You tell someone you'll be there. Be there. Don't flake out in life in anything. Just always uphold your word. So I told you last night. I texted you. I said, "Listen, I'm sick, but I wanted you to know I'm in. I'm not gonna be on my best game physically. I may not sound great. I may have puffy eyes. I didn't sleep well, but not the end of the world." So
awesome.
I appreciate you. I appreciate the content you put out for all the years. If it wasn't for you starting the channel, millions of men would be suffering far more than they need to. So I'm sure but it's nice to hear it again. You saved millions of people around the world with the fact that you put this platform together.
Yeah, well, I certainly hope so. Thank you so much, Gil, for all your contributions you did the last few years. Thank you.
Pleasure. Thank you so much again.
Okay, talk to you next time. Bye-bye,
Yes,
Gil.
sir.
Bye.
Bye-bye.